ايه ماكو مشكلة. هاي 26 العدد.
Assalamu alaikum. My seminar today is about the anatomy of the spleen and portal system. First of all, we will start with the spleen. The spleen is usually a wedge-shaped organ, soft, highly vascular, is about fist size, and surrounded by a fibroelastic capsule which allow it to significantly increase in size when necessary. About the microscopic anatomy of the spleen, as we can see by this image. Okay, the spleen is divided into two compartments, which is a white pulp and a red pulp. And these are interwoven in a connective tissue. We call them splenic cords. The white pulp is within the red pulp. This is the white pulp. Within the red pulp consists of a little foci of lymphoid tissue. And the red pulp is composed of blood vessels and splenic sinusoid. This microscopic anatomy is the reason for the cotton wool appearance of the spleen during the early arterial phase of contrast enhancement. Regarding the embryological development of the spleen, as we know, the GIT in general develops from three. We have ectoderm, endoderm, and mesoderm. And the spleen develops from the mesodermal origin. It arises from a mass of mesenchymal cells. The spleen arises from mass of mesenchymal cells which are located in the dorsal mesentery between the aorta and the stomach. This is during the 5th week of embryonic life. Then the spleen and the stomach rotates to the left and the liver to the right side. Location of the spleen. The spleen is located in the left upper quadrant of the abdomen, adjacent to the 9th, 10th, 11th rib, and it is posterior to the mid-axillary line, and its axis is along the 10th rib. Regarding the diameters of the spleen, it's 12 centimeter long, 5 centimeter width, and 3 to 4 centimeter thickness. This is a Harris diagram to help you memorize the diameters of the spleen. We have 137, which are the diameters of the spleen. 1 inch thickness, 3 inches breadth, and 5 inches in length. It is 7 oz in weight, which is about 150 grams, and overlying the 9th to 11th rib. The splenic surfaces, we have a diaphragmatic surface and a visceral surface. The diaphragmatic surface of the spleen is usually smooth and related to the costodiaphragmatic recess of the pleura, which can reach as far as the inferior margin of the spleen, and it is related to the 9th, 10th, 11th rib. This is the phrenicocholic ligament extending from the diaphragm to the splenic flexure of the colon, which will prevent the downward displacement of the spleen. And it is because of this ligament, we all know that clinically the enlargement of the spleen is toward the right iliac fossa, because this ligament, it will prevent its downward enlargement toward the left iliac fossa. Regarding the visceral surface of the spleen, as we see, there's an anterior end, posterior end, a superior border, which is notched, and an inferior border. This notch in the superior border of the spleen confirms its embryological origin from multiple small notches or splenios that will fuse together. And it has 3 impressions: gastric impression, colic impression, and renal impression. The gastric impression is related anteriorly to the fundus of the stomach, and the colic impression related to the splenic flexure of the colon inferiorly, and the renal impression related to the anterior surface of the left kidney posteriorly. We have the splenic hilum, in which the splenic artery and vein, they arise in, as numerous small branches. Okay, the visceral surface is usually directed anterior, inferiorly, and to the right. The peritoneal coverings of the spleen. The spleen is an intraperitoneal organ. It's covered by the visceral peritoneum on all its surfaces except at the hilum of the spleen, where splenic artery and vein pass, and this is the area where it is peritoneal free. Okay, sometimes the spleen, it will fuses with the anterior surface of the left kidney, forming what we call it the bare area of the spleen. The splenic ligaments, we have the splenocholic ligament inferiorly and the phrenicosphlenic ligament superiorly. These ligaments, they provide attachment for the spleen. And we have the gastrosconic ligament and splenorenal ligament. The gastrosconic ligament, we have the short gastric and the left gastroaortic vessels, they pass through this ligament. And the splenorenal ligament, which contain the splenic vessels and the tail of the pancreas. Okay, the anterior lip is the attachment of the gastrosconic ligament, and the posterior lip is of the hilum is for the attachment of the spleen or renal ligament. As we said, the splenic ligaments, we have 5. The gastrosplenic and splenorenal are the most important. The gastrosplenic connecting the fundus of the stomach to the anterior lip of the hilum of the spleen, and it contains short gastric vessels on the left gastroepiploic. And splenorenal, which contains the connects the anterior surface of the left kidney with the posterior lip of the hilum of the spleen, which contain the tail of the pancreas and the splenic vessels. We have splenophrenic and splenocolic. Splenophrenic was a suspensory ligament of the spleen from the diaphragm, and a splenocolic connecting the spleen to the splenic flexure of the colon. And the phrenicocholic, which is called the substentaculum lenis, it is supporting the spleen, preventing its peritoneal fold extending from the left colic flexure to the diaphragm. This diagrammatic representation shows us the gastrosplenic ligament from the fundus to the anterior lip of the spleen, and this is the splenorenal ligament. This is the posterior view, as we can see. This is the splenorenal ligament, and this is the splenophrenic, and this is the splenocolic ligament, and this is the phrenicocholic. Seen from anteriorly, as we see, this is the gastrosplenic ligament, and posteriorly we have the splenorenal ligament, and this is the tail of the pancreas, and these are the contents as scenic vessels, and here we have splenic artery and vein and the tail of the pancreas. Regarding the blood supply of the spleen, we have the splenic artery and venous drainage is by the splenic vein. The splenic artery is usually tortuous, running on the superior surface of the pancreas, and it will enter the splenic hilum as multiple small branches. Okay, it will give the short gastric and the left gastroepiploic vessels, which arise from the celiac trunk, while the splenic vein, it arises as similar small branches from the hilum of the spleen. It will receive the short gastric and the left gastroepiploic vessels. Behind the body of the pancreas, it will receive the inferior mesenteric vein, and behind the neck, it will receive the superior mesenteric vein to continue as the portal vein. The splenic artery and vein are end vessels. Okay, they have no collateral anastomosis. Regarding the lymphatic drainage of the spleen, we have the splenic hilar lymph nodes, goes to the retropancreatic group of lymph nodes and then to the celiac lymph nodes, and the innervation into the sympathetic and parasympathetic fibers coming from the celiac plexus. Splenic variants. We have the common splenic variants, the spleniole, which is an accessory spleen, anatomical asplenia, in which we have no anatomical spleen present, and this is usually associated with right-sidedness or right isomerism. Functional asplenia, in which we have a splenic tissue, but it is not functioning, and this is usually detected by scintigraphy. Wandering spleen, when we have a lax or abnormally long splenic ligaments, and causes the spleen to wander inside the abdomen and may tort around its vessels. And polycyphenia, which means multiple small rudimentary splenic bodies, and usually associated with left isomerism. Okay, spleniole. This is a focus of a normal splenic tissue separated from the main body of the spleen because of embryonic failure of effusion. As we said, the spleen forms from multiple small nodules, so failure of effusion, it will cause an accessory spleen or a spleniole. This commonly occurs in the splenic hilum or pancreatic tail, but can be seen in the small intestinal mesentery or the greater omentum. 10% of normal adults, they will have an accessory spleen in addition to their normal spleen. It can be identified by ultrasound by demonstrating its supply by splenic artery and drainage by splenic vein. This is an abdominal ultrasound showing the accessory spleens separated from the spleen. And this is an axial CT scan with contrast showing the accessory spleen. The polycyphenia, what is polycyphenia? It means multiple small rudimentary splenic bodies and associated with a bilateral left-sidedness. And it is usually associated with congenital heart diseases and isomerism and may occur in the right and left upper quadrant. And this reflecting the development of the spleen and the heart at the same time of intrauterine life. So what do we mean by isomerism? As we know, this is the situs solitus, which is the normal anatomical arrangement of the human body. The right lung is 3 lobes, the left lung is 2 lobes, and this is the normal anatomy of the heart. The liver on the right, spleen and the stomach is on the left side. We have situs inversus totalis, in which we have complete inversion of the abdomen, of the thorax and the abdomen. In situs inversus thoracis, we have the left lung on the right and the right lung on the left, and the heart is inverted also. In situs inversus abdominalis, the thoracic cavity is normal and the abdominal cavity is inverted. While in left-sided isomerism, we have it's usually associated with the polycyphenia. Each half of the human body is a reflection of the normal left side. So as we can see, both lungs are consist of two lobes, and the heart side, both are mirror images of the left side, and the spleen is in the midline, and this is the stomach, and we have the polycyphenia, multiple small rudimentary splenic bodies. And the right-sided isomerism is associated with acepenia, in which the human body is a mirror image of the normal right side. As we can see, both lungs are three lobes, and the heart, we have mirror image of the right side of the heart, and the liver is in the midline, and this is the stomach and absent spleen. This is a CT finding of a heterotaxia syndrome. What do you mean by heterotaxia? Hetero means abnormal, and taxia means arrangement. And this is on all the left and right-sided isomerism are all examples of heterotaxia. The CT scan of a left isomerism shows a huge midline liver with a contrast. We have the stomach on the right side, and we have polycythemia, multiple small spleens. And there is no IVC, as we can see, you have the azygous vein on the right side and the hemiazygous vein on the left side. And there is no IVC. Functional acepenia. As we said, this occurs when splenic tissue is present, but it is not functioning, occur because of its interruption of the blood supply, as in autosplenectomy in sickle cell anemia or diffuse diseases. And no spleen is seen by imaging studies like scintigraphy, which depend on a functioning splenic tissue. As we can see here, that there is an anatomical spleen, but it is not functioning, so it does not take the sulfur colloid scintigraphy. While we have the wandering spleen, it's a rare condition characterized by abnormally lax, deficient, or long splenic attachments, which will allow the spleen to move in the abdomen and possibly tort on its pedicle. As we can see that the spleen is in the right iliac fossa and coronal CT scan, and these are the splenic vessels and may cause a torsion around this pedicle. And there is a condition called splenosis. Splenosis means an autoimplantation of the spleen in any part of the peritoneum following splenic trauma. And this can be detected by scintigraphy with the technetium 99 labeled denatured RBC to detect any residual splenic tissue. Regarding radiological features of the spleen, we have the plain film, abdominal X-ray, ultrasound, CT scan, MRI, and the scintigraphy. Radiological features, as a plain abdomen, the spleen is usually not visible, but sometimes the lower wall can be outlined by fat. This relationship to the 9th, 10th, 11th rib is important to remember in cases of trauma. This causes a completely shattered spleen or splenic injury. Assessment of this size by plain abdominal X-ray is by measuring its length from the dome of the diaphragm to the tip, and usually it is less than 14 centimeters. Okay, this is on plain abdominal X-ray showing a calcified tortuous vessel, and this is a splenic artery. It's usually the veins, they do not get calcified. And this is a splenic cyst calcified, as in case of TB or hydatid cyst of the spleen, and this is calcifications of the spleen. Ultrasound of the spleen. As we know, the spleen, it has echogenicity less than the liver, but more than the adjacent left kidney. Its longitudinal axis on ultrasound is usually up to 14 centimeters in diameter, measured at the level of the hilum. Regarding CT scan of the spleen, this is an abdominal CT scan axial with contrast showing the spleen and its relation to the tail of the pancreas. Regarding CT scan, when we use the contrast, the spleen is usually seen homogeneously enhancing on contrast CT scan during the venous phase. During the early arterial phase, we have pulsating pattern of enhancement of the splenic sinusoid, which is the microscopic arrangement of the spleen. So we can see parallel bands of enhancement surrounded by or separated by non-enhancing connective tissue. Spleen is said to be enlarged if we see it anterior to the aorta or extending below the ribs. As we can see here, this is post-contrast enhancement. Post-contrast enhancement, we see the zebra spleen. It's a radiological sign used to describe the normal pattern of the splenic sinusoid enhancement, separated by the splenic cords. This occurred during the arterial phase of CT and the MRI study when injected with contrast. This is the early arterial phase. We can see the cotton wool spleen. And this is the homogeneous enhancement occurring in the portal venous phase about 50 seconds following contrast injection. Regarding the MRI of the spleen, on T1 weighted MRI, the spleen is usually hypointense to the liver because it has more watery content and the liver contains more fat. While on T2 weighted MRI, we have the spleen is usually hyperintense to the liver because it has more water content than the liver. Sometimes when we have a poor differentiation between the normal spleen and masses, it can be improved by the use of the reticuloendothelial system contrast agents. These contrast agents will form a dark background, so the abnormal masses, they will stand out as a hyper-intense area on this dark background. In cases of hemochromatosis, in which there's accumulation of iron inside the body, either primary or secondary, the reticuloendothelial system is the site of this iron deposition, resulting in a dark liver and spleen on MRI. What is the reticuloendothelial system? This means they're formed by phagocytic cells of the immune system in the lymph nodes and the spleen and the Kupffer cells of the liver. These cells, they take the iron peroxide, and this causes these organs to be very dark on MRI. This is an MRI showing a reduction in the signal intensity of the liver in a case of a hemochromatosis. Okay, this is the same patient after multiple sessions of phlebotomy, and we notice that the liver gained back its normal signal intensity. And this is again reduction in the signal intensity of the liver and the spleen in a case of secondary hemochromatosis. This is also an abnormal MRI T2 showing the degree reduction in the signal intensity in both the liver and the spleen in a patient with multiple blood transfusions as in patient with thalassemia. So this is a case of secondary hemochromatosis. The scintigraphy, which is we inject the technetium labeled silver colloid IV and we image by a gamma camera. And these colloid, it will taken up by the Kupffer cells of the reticuloendothelial system. And the activity can be seen, for example, in the spleniole in addition to the normal spleen and liver. As we can see, this is an axial CT scan showing the spleniole, and this is the spleniole by scintigraphy. Coronal CT scan showing the accessory spleen, and this is also seen by scintigraphy. Okay, any question before we proceed forward to portal venous system? No, sir. Okay, proceeding with the portal venous system. Okay, the portal venous system, the blood of the human body from the GIT, except from the anus, which usually its blood supply comes from the middle rectal and the inferior rectal, which are branches of the systemic circulation. The spleen, the anus, the pancreas, the gallbladder, will drain to the liver via the portal venous system. So all the GIT except the anus, it will drain to the portal venous system. It consists of superior mesenteric, inferior mesenteric, and splenic veins, which will unite to form the portal vein. In the fetus, it contains valves, but in adult, it is valveless. Okay, as we can see by this image, this is the splenic vein, and it will receive, this is starting as multiple smaller branches from the spleen at the hilum. It receives the short gastric and left gastroepiploic vessels from the stomach and forming the splenic vein. Okay, behind the body of the pancreas, it receives the inferior mesenteric vein. The inferior mesenteric vein, it receives the same tributaries as the inferior mesenteric artery, which are the superior rectal veins, the sigmoid veins, and the left colic vein. Okay, with the inferior mesenteric vein, after joining the splenic vein, behind the neck of the pancreas, it will receive the superior mesenteric vein to form the portal vein. The tributaries of the superior mesenteric vein, it is the same as the artery, but it is different proximally. The same as the artery, on the left side, it will receive the jejunal and iliac branches. On the right side, it will receive the ileocolic, the right colic, and the middle colic branches. Okay, the difference is proximally. It will receive the right gastroepiploic artery and the inferior pancreaticoduodenal artery. This is the right gastroepiploic and the pancreaticoduodenal veins, sorry, not arteries. Okay, after joining the splenic vein and forming the portal vein, it receives the right and left gastric vein and the superior pancreaticoduodenal vein. Then the portal vein, it will continue in the free edge of the lesser omentum, the hepatoduodenal ligament. At the porta hepatis, it will divide into the left portal vein and the right portal vein. Okay, as we can see here, this is the splenic vein. This is the inferior mesenteric vein joining behind the body of pancreas. And this is the superior mesenteric vein with all its branches the same as the arteries, with the branches joining the portal vein itself. One of them is the left gastric vein, and it will divide into the left gastric and right gastric. The cystic vein, when present, it will join the mesenteric vein. As we said, it is supplied by the artery, but the difference is proximally. It receives the right gastroepiploic and the inferior pancreatic duodenal. Okay, and this is the difference. We have the right gastroepiploic and the inferior pancreatic duodenal, and the jejunal and the other branches on the left, and ileocolic, right colic, middle colic on the right side, just like the artery. The inferior mesenteric vein usually lies to the left of the inferior mesenteric artery and drains its area of supply, the same in the colon. As we said, the superior rectal, the sigmoid, and the left colic. This is the superior rectal and sigmoid and the left colic branches, and some pancreatic branches also draining into the inferior mesenteric vein. The splenic vein, it will be formed by 4 to 5 branches, which will leave the splenic hilum. Occasionally, we have a vein called superior polar vein arise from the upper pool of the spleen to join the splenic vein more proximally. As we said, it will receive near the hilum, the short gastric vein and the left gastroepiploic vein from the stomach. Posterior to the tail and the body of pancreas, it will receive multiple pancreatic branches and the inferior mesenteric vein. This is the inferior mesenteric vein. And behind the neck of the pancreas, it will join the superior mesenteric vein to form the main portal vein. What are the relationships of splenic vein? Superiorly, we have the splenic artery, anteriorly straight to the pancreas, and posteriorly the left kidney, the left cross of diaphragm, left psoas muscle, and left sympathetic trunk and aorta. The tributaries, as we said, the short gastric veins, the left gastroepiploic vein, inferior mesenteric veins, and pancreatic veins. The splenic vein this is an abdominal ultrasound, is an important anatomical landmark for localization of the pancreas during abdominal sonography, and its diameter is up to 1 centimeter, more than 1.2, it will suggest portal hypertension. The portal vein itself, the portal vein is formed by the union of the superior mesenteric and splenic vein behind the neck of the pancreas, and usually at the level of L1, L2 lumbar vertebra. As we said, behind the neck of the pancreas, it receives the superior pancreatic duodenal. We notice that the inferior pancreatic duodenal will drain to superior mesenteric vein, while the superior pancreatic duodenal, it will drain into the portal vein itself. Behind the first part of the duodenum, it will receive the right gastric and left gastric veins, which are the coronary veins. And near the porta hepatis, it will divide into a right and left branches. The portal vein, after formation behind the neck of the pancreas, it will pass to the right behind the first part of the duodenum and the free edge of the lesser omentum hepatoduodenal ligament, posterior to the common bile duct and hepatic artery. Here it is separated from the IVC by the epiploic foramen or foramen of Winslow. The relationships of the portal vein anteriorly is the neck of the pancreas and the first part of the duodenum. Anterolaterally, we have the CVD, anteromedially, the common hepatic artery, and posteriorly, the IVC separated from it by the epiploic foramen. This close proximity between the portal and splenic can be used for surgery in portosystemic venous shunting. As we said, this is the portal vein forming the left portal, the right portal branches are the porta hepatis. The left portal, it receives the segments of the left lobe, 2, 3, and 4. Okay, as we can see here, the ligamentum teres and its continuation, the ligamentum venosum, are attached to the left portal vein. These are embryological remnants of the umbilical vein. When we have portal hypertension, we will have recanalization of this umbilical vein, or the round ligament, which is the remnant of the umbilical vein. The right portal vein, it will receive to divide into right anterior and right posterior. Right anterior to receive from the right anterior segments of the liver, segments 5 and 8, and the right posterior to receive from the posterior segments of the right lobe, which is segments 6 and 7. The right portal vein to receive the cystic vein when it is present. Okay, again, this is left portal showing the draining segment 2, 3, and 4, and also the caudate lobe, it will drain into the left portal vein. While the right portal to receive the right anterior and right posterior, this is draining 5 and 8, and this is draining 6 and 7. This is an MRV showing the splenic vein, and this is superior mesenteric vein forming the portal and dividing into right and left branches. This is an MRI T1 showing the portocaval space, and this is an area of a normal lymph nodes, which can be enlarged in pathological conditions. The portosystemic collaterals, when we have portal hypertension or portal venous pressure is raised, so the obstruction to the bowel flow in this portal vein and the hepatic veins, we will have collateral. As we can see here, we have the left gastric vein, which is a branch, as we said, of the portal vein. It has an anastomosis with the esophageal vein, which is a branch of azygos vein. So it's connecting the portal system here with the azygos, which will drain to the superior vena cava. Okay, so when we have a portal hypertension, we'll have a dilated esophageal varices forming this shunting of the blood, and patient presents with an acute upper GIT bleeding. Okay, the second site of anastomosis between the inferior rectal veins and the superior rectal veins. These are branches draining into the iliac, into the IVC, and these branches drain into the port with hemorrhoid. The third site of anastomosis is between the umbilical vein. As we can see here, we have recanalized umbilical vein, which is attached to the left portal vein, as we said, and in the branches of the inferior epigastric vessels or inferior epigastric vein. Here, this site of anastomosis, when we have portal hypertension, it will form the dilated superficial veins. We call it capitomucosa. And the fourth site of anastomosis is in the colon. We have the retroperitoneal veins with the branches of the colic vein. These will forming anastomosis between the IVC and branches of the portal system. When you have portal hypertension, we have congestion of the bowel. So these are the sites of portosystemic anastomosis, as we said, at the gastroesophageal junction between the left gastric vein and esophageal veins, in the rectum between superior rectal veins and inferior rectal veins, the retroperitoneum, which are tributaries of the mesentery with retroperitoneal or the renal, lumbar, or phrenic veins, and at the umbilicus by the parumbilical vein, which will get recanalized with the veins of the anterior abdominal wall. This is a case of esophageal varices. As we can see, this is a transesophageal ultrasound showing the esophageal varices. This is an OGD showing the appearance, the worm-like appearance of esophageal varices. Can be diagnostic and therapeutic here. And this is in severe cases, we can see the esophageal varices by plain abdominal X-ray or chest X-ray. Paraumbilical, this is a paraumbilical collaterals. You can see here recanalized umbilical vein connected to the veins of the anterior abdominal wall, and we can see here a portocaval collateral near the liver hilum. So how to diagnose portal hypertension? By detection of the portocaval collaterals at the porta hepatis. The portal vein diameter is usually more than 1.5 cm. Dilated splenic vein more than 1.2 cm. Splenomegaly, ascites, recanalized umbilical vein, and esophageal varices or hemorrhage. Regarding the radiological features of the portal venous system, we have plain film, ultrasound, CT, the MRI, and the portograph. This is a plain abdominal X-ray. We cannot see the portal vein by plain abdominal X-ray, but we can see the portal venous gas. As we said, this is the pneumobilia, which is usually central gas, and this is the portal venous gas, which is usually peripheral, because the blood flow is usually peripheral in the portal vein toward the liver and can reach up the periphery of the liver. This can be seen in cases of pneumatosis intestinalis, in which there is a gas in the bowel wall, and usually the patient is very ill, and sometimes can be seen when we insert feeding duodenostomy, when there is any damage to the mucosa and the gas bubbles, they may enter the portal system. This is, as we can see in this abdominal X-ray, there's a connection between the IVC through a shunt and the portal vein. So this is a case of transjugular intrahepatic portosystemic shunting of the blood in case of portal hypertension. By ultrasound, as we said, the portal vein lies posterior to the hepatic artery and the CVD. The diameter is variable, but it's usually greater than the normal bile duct. It's up to 13 millimeter. More than 1.5 cm, it is considered portal hypertension. Portal venous branches are usually have echogenic walls more than the bile ducts, and usually because it is accompanied by the bile duct and the hepatic artery, so the portal vein branches are echogenic. The color Doppler will help to identify the vessels, while the pulse Doppler will show the direction and the velocity of the blood flow. As we see, this is the portal vein, the hepatic artery, and the bile duct. Okay, this is a pulse Doppler, okay, showing that the blood flow is toward the liver. It is hepatopedal, toward the liver. This is a case of a portal vein thrombosis. As we can see here, this is a thrombus inside the portal vein, and this is the blood flow, the absent blood flow toward the liver in the portal vein. On CT scan, it is, as we said, it's posterior to the bile duct and the hepatic artery. and pass in the porta hepatis separated from the IVC by the erythroid foramen. This is the IVC. This is an axial CT scan with a contrast. This is the hepatic artery, and this is the main portal vein. On MRI, you have the MR angiography of the portal system without a contrast using the time of a flight sequence. This is usually an MRV. This is an excellent technique to provide detailed information about the portal vein and the portosystemic collateral vessels. As we can see, this is the main portal, the left, right portal, right anterior, and right posterior. Portography. Portography is a radiography of the portal vein after the induction of opaque radioactive contrast, radio contrast agent. It's of two types, either direct portography or indirect portography. The direct means that we are injecting the contrast directly into the vein, while the indirect portography is by injection into the artery and taking the image during the venous phase. The direct portography, we have either splenoportography or transhepatic or transumbilical. Splenoportography, the contrast is injected directly to the spleen, and we must be assured that there is no lesion in the spleen to inject the contrast inside it, and it will outline the splenic veins and the portal vein. And we have the transhepatic or transjugular, is by the cannulation of the portal vein or injection of the contrast into the splenic vein or the portal vein, and this can be used to sclerose esophageal varices. Okay, and the transumbilical in the neonate by catheterizing the umbilical vein. An indirect portography by injection the contrast into the arteries, either celiac, mesenteric, and inferior mesenteric, sequentially or together, and the film usually is taken in the venous phase. Okay, usually we prefer the mesenteric artery because it is the direct continuation of the portal vein. In portography, sometimes if the spleen is very large, the splenic vein, they cannot be seen because of the pooling of contrast inside the spleen. And the flow of the blood in the portal system is usually slow. And this is a poor mixing of the blood from the splenic vein, which is usually supply the left lobe, and the superior mesenteric vein, which usually supply the right lobe. So not to be misinterpreted when only one artery is injected. Contrast preferentially fill the right lobe of the liver in a supine patient because of its more posterior position. And to overcome this, it may be necessary to rotate the patient. Again, portal venography, you have direct portography, either splenoportography or transjugular, transhepatic, or transumbilical, while indirect is by the late phase superior mesenteric artery angiography. This image, as we can see, this is an fluoroscopy image showing we have the catheter is inserted directly inside the portal vein, or either by transhepatic route or transjugular route. And here we inject the contrast to see the branches of the portal vein. This can be used to sclerose esophageal varices because the left gastric vein is a branch of the portal vein, so we can sclerose it directly. And sometimes it is used to take blood for venous sampling in a case of hormonal secreting endocrine tumors of the pancreas, which are usually difficult to diagnose, to confirm diagnosis. This is also a form of direct portography, as we can see that the contrast is injected directly in the spleen, and this is the splenic vein and the portal vein. This is a case of indirect portography, also by fluoroscopic image. We inserted the catheter by Seldinger technique into the femoral artery, and then we can see this is the catheter in the midline in the abdominal aorta. This is the catheter tip inside the celiac trunk. Okay, as we see, we injected the contrast into the artery, and then we take the image in the venous phase. This is the splenic vein, clearly. This is the splenic vein, and this is the portal vein, the right portal vein, and the left portal vein. So this is a form of an indirect portography using the superior mesenteric, using the celiac trunk. The CT arterial portography. Okay, this imaging is usually done by selectively catheterizing the superior mesenteric artery, and we inject the contrast into the superior mesenteric artery, and we'll take the image during the venous phase. So the artery is injected, and we take the image in the portal or portal venous phase. Okay, because the majority of hepatic tumors are supplied by the hepatic artery. Okay, so it is used to evaluation of resectable liver tumors. As we can see here, that as we know, because the portal vein provides 75% of liver blood supply, and hepatic artery provide 25% of the blood supply. So as we can see here, that the contrast enhanced liver, okay, and the arterial dominant lesion here show no contrast enhancement. And also to evaluate if this tumor we can use the hepatic artery embolization as a treatment method for this lesion, because there will be no infarction of the liver because of its dual blood supply. And thank you.